Good morning all. Today's class we will be discussing regarding the genital tract injuries. So as we know that the genital tract and the adjacent pelvic organs are subjected to strain of vaginal delivery, either spontaneous or assisted, and the injury is more in areas of inadequate antenatal and intranatal care. The patients may have full recovery from the injuries, but a substantial number may produce permanent legacies which lead to major gynecological problems. So I will show you some of the obstetrical legacies leading to gross gynecological problems, that are genital prolapse, perineal injuries including complete perineal tear, genitourinary and rectovaginal fistulas, then tender perineal and vaginal scars, then backache, aversion cervix with cervicitis, ill health and chronic debilitating state. So in first picture you can see that is diagrammatic representation showing different degrees of perineal tear from, that is, posterior vaginal wall. Skin you can see first degree, second degree, third degree and fourth degree. So this note is taken from DC Datta. So first we will see regarding the CPT, that is complete perineal tear. Tear of the perineal body involving the sphincter ani externus with or without involvement of the anorectal mucosa is called complete perineal tear. It is called old when passed beyond an arbitrary period of 3 months following the injury. So, what do you mean by CPT, tear of the perineal body? It is involving with or without the involvement of the anorectal mucosa is called complete perineal tear, and the particular perineal tear already passed 3 months means we can call it as it is old complete perineal tear. Next we will see the classification of perineal tear. So classified into 4, that is first, second, third and fourth degree. First degree we will see the features, that is laceration of vaginal epithelium or perineal skin. Second degree, involvement of the perineal body but not the anal sphincter. Third degree, that is disruption of the anal sphincter complex, both external and internal. Fourth degree, injury to the anal sphincter complex with tear of the anal epithelium. So next we will see regarding the etiological factors. So complete perineal tear etiology is divided into 2, that is obstetrical and gynecological. Obstetrical, that is perineal injury third and fourth degree, result from overstretching or sudden stretching due to childbirth. As we know that during the childbirth there is stretching of the perineal muscles are happening. So because of the overstretching or sudden stretching, what will be happening? There will be injury to the perineal muscles. So it is more common when the perineum is inelastic. So the perineum is not at all elastic. Suddenly when the stretching is happening, there will be chance of getting the injury. So the risk factors for third degree tears are primigravida. Then if the baby is big, that is above 3 kg, then there is face presentation, midline episiotomy has done, forceps delivery, outlet contraction with narrow pubic arch, shoulder dystocia is there, then precipitate labor, scar in the perineum, prolonged second stage. So all these risk factors are contributing to the third degree tear. Next we will see the gynecological factors, that is direct injury on the perineum by fall may lead to trauma on the perineum to the extent of CPT. So maybe the woman is falling, so direct fall, and it may lead to the trauma to the perineal area. So what are the structures that get torn in CPT? That is posterior vaginal wall or perineal skin, perineal muscles, perineal body, anal sphincter complex, varying degrees of anorectal mucous membranes. Next we will see regarding the clinical features. So as we know that patient profile, that is patients are usually primiparous with a history suggestive of inadequate care during childbirth. Then symptoms are, the chief complaints are inability to hold the flatus and feces. While incontinence of flatus is invariable, that of feces depends on the extent of damage of the external anal sphincter If the damage is slight, there is incontinence of only loose stool, but if the damage is severe, there is incontinence of hard stool as well. Then second thing is soreness over the perianal region is due to constant irritation by the stool. It is often surprising that the condition may remain asymptomatic for many years and only discovered accidentally during pelvic examination. Overactivity of the levator ani makes the patient consistent with the stool, continent with the stool. So the incontinence of flatus being ignored. Then what are the signs? Inspection of the perineum reveals, when you inspect the perineum, you can see there is absence of perineum, vaginal and rectal mucal membranes are found to be continuous, only separated by a bridge of fibrous tissue, that is rectal mucosa is reddish and the vaginal one is pink in color. Then visible dimples on the skin on either side of the fused mucosa may be present, and these represent the retracted torn ends of the sphincter ani externus which have got subcutaneous attachment. Then radial wrinkling of the skin is present only on the posterior aspect of the anal opening. Then if you do the palpation, you can see there is absence of the sphincteral grip evidenced when a finger is introduced into the rectum, and the anal canal is separated from the vagina only by a septum. It is surprising that in spite of deficit of the perineum, there is no prolapse. This is because of overactivity of the levator ani muscle. If prolapse is found along with the CPT, it is more likely pre-existing. Next, we will see the differential diagnosis. The rectovaginal fistula situated low down may at times be confused with complete perineal tear. This is especially in cases where overlying skin remains intact. Rectovaginal fistula causes more inconvenience to the patient than CPT. So next one is treatment. Treatment is preventive and operative is there. In preventive, there is proper conduct in the second stage of labor, taking due care of the perineum when it is likely to be damaged, and it is effective step to prevent the undue lacerations. So once you find that there is a chance of getting the perineal tear, what you have to do is undue care you have to take to avoid the damage of the perineum. Then the prevention of the perineal injuries in normal delivery include, we have to give more attention, should give it to the perineum, but to be controlled delivery of the head. Then delivery by early extension is to be avoided. Flexion of the head is to be maintained till the subocciput comes under the symphysis pubis, so that lesser subocciput of frontal, that is 10 cm diameter, emerges out of the interosseous. Then the prophylaxis to perineal injuries during delivery. Delivery of the head by early extension is to be avoided. Controlled delivery of the flexed head in between the uterine contractions. Timely and judicious mediolateral episiotomy, especially in primigravida, occipito-posterior, face, breech or forceps delivery. Then spontaneous forcible delivery of the head is to be avoided by assuring the patient not to bear down during the contractions. Pressing on the head and the perineum by the palms and giving inhalation analgesics if available. To deliver the head in between the contractions. To perform timely episiotomy when needed. To take care during delivery of the shoulder as the wider bisacromial diameter, that is 12 cm, emerges out of the interosseous. So next one we will see regarding the operative procedure in next video. Hope you understood regarding the genital tract injuries. Please subscribe and share to your friends, and please see the next video also. Thank you.